The Nordic Maintenance Care Program. Chiropractors would like to be thought of as preventive. We hope to be included in professions such as dentistry who have established the benefit of regular checkups. In other words, regular checkups and maintenance care would help prevent future occurrences of spinal pain. Maintenance care is an approach to management not based on symptoms but based on prevention of recurrence or progression, utilizing treatment when the patient is asymptomatic. It is, however, applied in an inconsistent manner. Regardless, at its core is an attempt to maintain normal spinal biomechanics and prevent recurrent pain through preserving proper motion of joints and, in some models, address the overall muscular system that supports the spine. Unfortunately, some use maintenance care as an opportunity to increase their per-patient averages as part of a more stable revenue source, regardless of whether they believe in the benefits. Interestingly, little research has been performed on the benefits of maintenance care, partly due to the wide range of application, but secondly because the search for which outcome to measure as an indicator of success is inherently difficult. In other words, if maintenance care is effective, how would you know if it prevents something? Compared to what? There has to be a comparator, a non-maintenance group, and a relevant outcome of comparison. Thankfully, a recent study has begun to address this. The title of the publication is The Nordic Maintenance Care Program, Effectiveness of Chiropractic Maintenance Care versus Symptom-Guided Treatment for Recurrent and Persistent Low Back Pain, a Pragmatic Randomized Controlled Trial, published in PLOS One in 2018. The aim of the present study was to, quote, investigate the effectiveness of maintenance care as compared to chiropractic care given when there was a subject-perceived need in a population of chiropractic patients with recurrent or persistent low back pain, unquote. The outcome measure was viewed as a dichotomous question about, quote, bothersome pain to discriminate between pain that does and does not affect daily life. There are different definitions for maintenance care. According to the researchers, quote, maintenance care can be viewed as a form of secondary or tertiary prevention and may include manual therapy, individual exercise programs, and lifestyle advice delivered in regularly spaced visits over longer periods of time, unquote. Although there is moderate quality evidence that exercise combined with education reduces the risk of an episode of low back pain, there is little evidence for secondary or tertiary preventive strategies. The debate is, does the doctor determine the frequency of care after the acute management is over, or is it the patient's choice? And based on what? So, is it maintenance care or treatment only when there is perceived need by the patient, usually triggered by a recurrence of old complaints? This was a Swedish study. In Sweden in 2012, 12% of the total cost of musculoskeletal disorders was accounted for by spinal pain. About 20% of all visits to Scandinavian chiropractors are maintenance care visits, and 98% of Swedish chiropractors use the approach to some degree. The researchers noted that there are a number of predictors of success. For patients receiving manual therapy, one of the strongest known predictors of a positive outcome is subjective improvement on the fourth visit. These patients also have a greater chance of a good outcome at 3 and 12 months. So now to the inclusion-exclusion criteria. The inclusion criteria were ages 18 through 65, low back pain with or without leg pain for more than 30 days during the past year, previous episodes, access to a mobile phone and the ability to send and receive text messages, and self-rated, quote, definitely improved, unquote, by the fourth treatment. And the interval between treatments is 1 month or more. Exclusion criteria included pregnancy, chiropractic treatment less than 3 months ago, completely subsidized treatment from a third-party payer, or serious pathology or contraindications to manual therapy. It's important to note the sequence of this unique study. At the first visit, participants filled out a questionnaire of descriptive characteristics, pain intensity, self-rated health, and psychological and behavioral characteristics. At the fourth visit, another questionnaire was completed asking about subjective improvement and use of pain medication. At the study start, the final questionnaire in the inclusion process was administered in order to record further descriptive data activity limitation, and pain intensity. At the 12-month follow-up, the same forms were sent to participants. So who were the study clinicians? Patients were recruited between 2012 and 2016 from 40 Swedish chiropractors with clinics across Sweden. Based on a previous survey, chiropractors who recommended maintenance care to selected patients were identified and included in the study. These clinicians are a part of a practice-based research network and have been found to be a good representation of the chiropractors of the Swedish Chiropractic Association. Out of the 40 recruited clinicians, 5 eventually chose not to participate. There were 2 treatment arms of this study: a maintenance care group utilizing preventive treatment, which was clinician-controlled, and the control group, which was symptom-guided treatment and therefore patient-controlled. The researchers used a primary outcome, but also a number of secondary outcome measures. The primary outcome was the number of days with bothersome low back pain experienced during the 1-year study period. The information was collected by weekly text messages using an automated system called SMS Track. Specifically, the question was, quote, "On how many days during the past week were you bothered by your lower back? Please answer with a number between 0 and 7, unquote. And now the results. There was a primary and a secondary analysis performed. With the secondary analysis, only those participants with 4 or more visits in the maintenance care group were included. The secondary analysis revealed the following. The total number of days of bothersome low back pain over the 12 months was 89.1 days for the maintenance care group and 98 days for the control group. So let's review a number of factors. Both groups continued to improve during the first quarter of the study period and then appeared to stabilize. The maintenance care group had a faster reduction in days with bothersome low back pain and reached a level of stability earlier. The total number of visits over the 12 months was 6.7 for the maintenance care group and 4.8 for the control group. The effect of the intervention was achieved with only 1.7 additional visits to the chiropractor. The most common treatment was for the control and maintenance care groups respectively, spinal manipulation 85.5% and 94.2%, followed by information and advice and soft tissue treatment. Of the subjects who were eligible after the first visit, 32% were lost, and of the subjects who were eligible at the 4th visit, 25% were lost. With a significance level of 5%, it was estimated that 177 subjects were needed in each treatment arm to reach a power of 80%. To allow for dropouts, a total of 400 subjects were aimed for in the recruitment of this trial. The final analysis was conducted in April 2017 and included 319 subjects. During the 12-month study period, the maintenance care group reported 12.8 fewer days in total with bothersome low back pain compared to the control group. This did not reach, though, the calculated power level of 80%. Although the results are encouraging for decreasing the days for bothersome low back pain, and it appears that the response occurred earlier for those in the maintenance care group, the confusing correlate is the difference in number of treatments. How is it that the difference between maintenance care and the control group for an entire year is less than 2 visits on average? Is this truly representative of maintenance care? Certainly in the U.S., this small number of visits may not even represent usual chiropractic care. Also, it would be interesting to know if the number of visits is affected by reimbursement rates in Sweden. The small difference in visits between groups might explain why many of the p-values for the variance did not reach statistical significance, but why then did it reach statistical significance for the primary outcome? The statistics in this study are a bit confusing. The analysis is certainly confusing to those who are not biostatisticians, and perhaps therein lies the explanation. But until a larger study comparing the results of a group treated with more of a representation of maintenance care is conducted, it's hard to trust that only about 2 more visits a year is all that's needed to cause an effect.